Thanks to all our speakers today. And I know we have a number of questions and we have several doctors still in the room. So I think we may be pitching these questions to a couple different places. So first question was from Linda. This was online earlier, I believe. What is the approximate percentage of dissections in people that are aware of their aneurysm? I'm not quite sure what that's. What is the approximate percentage of dissections in people that are aware of their aneurysm? Do we know how many actually result in a dissection? I don't know. Who can answer that?
I don't know that I know the answer to that. So the question is, say it one more time.
If I know I have an aneurysm, or
Yeah.
people who know they have an aneurysm, how many actually result in a dissection? Do we know the percentage?
Yeah, well, we know that. I was thinking of it.
Yeah, it was kind of
that-
worded weird, but
Yeah, well, no, she may be asking that. So,
Right.
Okay, for example, we know the numbers. So if you have an aorta of 4 to 4.5 centimeters, we know what the risk is over like a 5-year. There was a nice Mass General study a couple of years ago. It just recently replicated in the Kaiser database. And your risk is actually really relatively low at those diameters. It goes up a little bit, but where it really tends to go up is somewhere, well, close to 6 centimeters it goes up, but the curves start to go up over 5 centimeters, and that's why in these most recent guidelines, they've actually shifted the surgical threshold down to 5 centimeters at centers of expertise. I think we could probably look at the question the other way too, but I'd say there's so many people that have aortic enlargement, but I honestly don't know how many of the dissections know that they have that preceding their dissection.
Great point.
Yeah, it's a very interesting question.
Right. Thank you. One other question from Christina. How likely is it for my descending aorta to rip towards the heart in the future? I dissected in 2014, was told from the heart into the left iliac. I now think that meant from the arch on down. Okay, so because all my scans reads by mention the diameter from the arch and other places in the aorta and iliac. So I guess the question is, how likely is it for my descending aorta to rip toward the heart in the future? And I suppose that's different for everyone, but
Do you know the answer to that? I'd say it's relatively, so it sounds like, if I understand the question, that the patient has a type B dissection, which I believe Dr. Beckman showed a slide of. So that's a dissection that starts distally, so often beyond the left subclavian, which supplies the blood to your left arm. It's relatively rare that extends retrograde into the arch in the ascending aorta. Things can happen like that. What we usually follow the type B dissections for, though, is progressive enlargement over time, and it depends on the flow patterns within the dissection, the true lumen, the false lumen, depends on whether that aorta will enlarge, and that usually is what we follow closely in those patients.
thank you. I think this question is probably for Danielle. How do I handle my anxiety without medication? I think we'd all like to know that.
I think that's a great question, and I think it kind of depends on the person. I would always say talk to a medical mental health provider. They can, recommend a lot of other things besides medication, such as psychotherapy, and then dive a little bit more into just like lifestyle of things that we can do, such as self-care with movement and nutrition, and how that can impact anxiety and things like that. So there's a lot of different things that you could do, but I would always recommend talking to a medical provider, mental health provider first.
Great. Are there any tests or scans to determine the thickness or thinness of the aorta? So how close the dissection might be to the outer wall? Any of the... Dr. Beckman?
That's a very good question, and I think we don't have a good test or tool to measure that. So most tests just measure the diameter of the aorta and tell us how thick or how dilated the aorta is. Most scans don't have a high resolution to tell us about the thickness of the aortic wall, but that would be a good parameter to tell us about the risks. You know, we only see that very often in the operation itself. When we open the aorta and look at the tissue, we say, oh, that's very thin and maybe fragile. But at the moment, I don't see any good test available that can measure the thickness of the aortic wall. But that would be a great thing to have in the future.
Great. Is there a difference between a pig or cow valve? Are there differences that patients should be aware of in the benefits of one of the over the other?
I think another good question. I hear that question very often in clinic or before surgery. So most valves are made from bovine tissue. That means from cows. But both are good. I mean, usually we choose the right valve for every individual patient in the operating room, and there are a couple of different valve types, and we don't really say this one is better or that one is worse. I think we make sure that the valve that we choose sits nice in the aorta or where we implant it. And I usually don't give a definite answer to that before the operation because every patient is different, and sometimes we choose this or that valve. I think just the type or the material of the valve is not the primary, it's not the most determining factor for durability or for the choice that we make.
Okay. I guess a question that I would have on top of that one is, do pigs or cows valves, bovine or porcine? Am I right? Awesome. Thank you, biology class. Do one or the other last longer than the other? No, they're about the same? Okay. Here's a question. Why aren't women with preeclampsia being given echo tests during pregnancy or shortly thereafter, especially after multiple pregnancies with preeclampsia? And I'm assuming, Karen, this means people who have a aortic situation already going on?
Well, so when you have preeclampsia, it can lead to very high.
Right.
It can lead to very high blood pressure. So I'm just wondering, as this was one of the things that happened to me way before I had my dissection, and I had pretty bad preeclampsia, and after I gave birth, I still had residual high blood pressure that never went away. And I took my medication, but wasn't very compliant because I didn't understand why it was really important. And then years later, I ended up having a situation, but my father also had an abdominal aneurysm. So it got me thinking after being in this community, why aren't women being tested if they have such incredible high blood pressure? I know you might want to know their family history, but it doesn't make sense. And I've heard women who have had multiple pregnancies, all with preeclampsia, and then I said, have these people had an echo? Like, what's going on with their aorta afterwards? So I'm just curious.
I wish Dr. Saxena was here for this.
I know,
for this question.
she was online with us
I
earlier.
know.
So
She may know the answer to that better than me, but I mean, I think we are now recognizing the importance of preeclampsia and other pregnancy issues and their long-term effects. It's an excellent question. Certainly, we know hypertension is a risk for development of an aortic aneurysm. I don't know that your question has been studied to my knowledge, but I think it's a great question. I would say that people often are fearful of an aortic dissection in pregnancy. That is, it happens. It's terrible, but it happens pretty rarely. And many times when that happens, there's an underlying aortic issue that just, whether it was recognized or unrecognized. The people that have aortic disorders going into their pregnancy, we follow them very closely during pregnancy. But many times the way we learn that they have a problem in pregnancy or when they have their dissection is retrospectively, unfortunately.
great. Is a low heart rate such as 52 beats per minute, concerning after repair. I'm not on any meds and did not have valve repair.
Well, Dr. Pai, I know, is working at the hospital right now, so he's not here for that. But I would say 52 without concerning symptoms deserves watching, but is not generally, I mean, generally the indications for pacing are if you have symptoms and a slow heart rate, generally not at 52 though, but might be something you want to talk to your cardiologist about. Drugs that we use after surgery or with aortic disease, specifically beta blockers, lower your heart rate, as do some of the other medications.
What are your thoughts, any of the professionals here today, what are your thoughts on chiropractic neck adjustments after a repair? It's a really interesting question.
Very interesting question. I don't know, sometimes you hear stories once in a while that a dissection occurs after a chiropractic maneuver. Oh, sorry, maybe I hold it closer to me. Sorry. So sometimes you hear stories that a dissection occurs after a chiropractic maneuver. I think these are very rare instances, and most chiropractic maneuvers go very well, but sometimes once in a while you hear about it. I don't know. I don't have any numbers, or I think there are no studies out there that prove that it's good or bad or something, but I have the feeling that you might want to be a bit careful about it, but I don't have any data suggesting that. I don't know if you have any other, just by feeling I would say maybe.
Well, I'm sure that if any of those situations do happen, that there's probably not a lot of data to correlate causation, or actually, right? It's just, I'm a data gal, so. Does anyone else have questions that you would like to ask? Terry.
I don't remember who was talking about it. I'm not sure if it was Danielle or one of the doctors online, but somebody was talking about telling people before their surgery, the elective surgeries, what's going to happen, what the mental capacity is, how you're going to feel, and all the things that can happen afterwards. But what is being done besides aortic hope? What is being done for those patients that have emergency surgery? Because if I wouldn't have known about aortic hope, who knows where I would be now? And I was on depression and anxiety medication, and I still suffered depression after my open heart surgery.
Danielle or Dr. Beckman? Right here.
I think that is a question that many patients after a dissection have. And I think, unfortunately, there's a lot of room for improvement. I'm not very familiar with this place here. I just moved here half a year ago, but I had the same issues in Germany. And I think the main problem is that it's so sudden, you know, you're very healthy, everything is fine, and then suddenly you have severe chest pain and you know that something is wrong. And you wake up, you go to the hospital, somebody tells you need surgery, and then one day later you wake up and everything is different. And I think in elective settings, there's a lot of time to process it, to prepare for that, talk to family members or watch videos online and prepare for that, you know, for yourself. And then you usually can maybe get acclimatized with it better. And it's a very good question. I hear that very often in clinic later on, what can I do now? I think immediately in the hospital, there's always, you know, psychology involved or the psychiatric services that can provide help. But sometimes, you know, once you get discharged, you have less resources, and those groups, I think, are a great thing for some people. I recommend in Germany, we had one big group that always met every month, and the patients with aortic disease could, you know, talk to each other. And I think for some patients, it's a good thing if you like to talk and exchange knowledge. For some, it's not a good thing. They are not, you know, every patient is different and every human being is different. But I think for some, like those groups are a good thing to connect, you know.
I can add a little bit from the caregiver perspective too, that I rave about being here in Minnesota and having Pete treated at the Minneapolis Heart Institute, because not only was his cardiologist, Dr. Campbell, a rock star through the entire 2 years of watch and wait, but Alex came here the very first rock from the heart, and in this group and meeting with that, The one thing he said to me afterwards was, I had no idea that you were living your life in 6-month chunks on a roller coaster between every scan. I'm going to take that back to clinic and think about that when I'm meeting with every patient, because every 6 months it was, you go, okay, we get to wait, and down you go, and you go 6 months, and then you're within 1 month of going back in, and the anxiety starts to set in. And that was for Pete, I know, and myself. Oh, we gonna go? Go under the, nope, not yet. And then finally, it was the day when they had the valve was severe, and Dr. Campbell looked at Pete and said, it's time to go. And Pete goes, yeah, time to man up and get this done. But not only that, but in the hospital for the surgery, before Pete was discharged, number one, if you can, always have a second set of ears there. Because I know Pete probably didn't hear a lot of what was going on, because there was everything. There's this, you've got left bundle branch block, so guess what? You get to have a bonus surgery on day 8 and get a pacemaker implanted, which was the last thing he wanted to hear. I went downstairs to get a cup of coffee after that and ran into Dr. Campbell, who said, hang on, we'll be up there. He came up, he sent a team to talk to Pete and explain what was going on, that it wasn't a big deal, and that was huge. Because when Pete found out he needed a pacemaker, I watched his SpO2 go from 98 down to 82, like that. It was that panic and that stress. They told us in the hospital, this is gonna happen. You are gonna have some depression. There's some mental health things. And it made all the difference in the world. And unfortunately, I don't think everybody is that lucky. So the more we can do, one reason why we bring mental health professionals as part of Rock from the Heart every year is because we see far too much where that person thinks they're alone. They think they're the only person that's feeling this way after their surgery. They need to know that it's normal to watch for the signs and to get the help when they need it. So that's just mine from the caregiver perspective, from being through it. Knowing what we had here was very, very special, and we thank each and every person at the Minneapolis Heart Institute and Abbott who took care of Pete during that time, because it saved his life.
What other questions?
Is there a chance that if you've been diagnosed with a bicuspid valve, that it can be mistaken for a tricuspid valve?
Another very good question. Yes, for sure. So the echocardiograms are usually done transthoracic. That means we take the probe and put them on the chest. And sometimes the images have poor quality or not perfect. We can also do an echo where you have a probe that you swallow. These pictures are way more exact. But still, even there's some chance that this is hard to catch, you know. So sometimes, I think, mostly the diagnosis is right, but still we have some cases where we bring patients to the OR because they have a stenotic or blocked aortic valve, and the report says tricuspid, and then we find out it's a bicuspid valve, or the other way around. That happens once in a while, not very often, but it can happen, because it's just images, and it's, you know, you never find out until you see the valve with your own eyes. But usually the pictures are very reliable.
Having thought about this a lot today as I was reading echoes, it can be kind of challenging, and I reported one of my echoes probably trileaflet because I thought I could see it, but I thought that was more accurate than just saying it was in a family member. But it can be really challenging on the echo, but the practical thing really then is following the valve over time, getting another echo down the road, but is the valve leaking? Is it stenotic? Is there aortic dilation? Those are the key clinical things that we hope to gain from the echo.
Any other questions? Oh. Keep them coming. We got a little time here.
So one of my brothers just had a mechanical valve put in about a year ago, and he also has aneurysms. Why would they have waited to repair the aneurysms now that his chest is totally cut open and he's, you know, and it's right there? Like, I understand before you replace the valve, you want to wait till it gets to a certain point. But if you're already in surgery and it's right there, why would you wait for that and have to go in then later?
Okay, thank you. So I guess you refer to an aneurysm that is located to the ascending aorta or aortic root. That's what I assume. And usually there are guidelines, they have like 100 or 200 pages and they give recommendations. And if we just replace the aortic valve, let's say the risk for the procedure is 0.5%, that something bad happens. And if we add an ascending aortic replacement, the risk increases maybe to 1 or 2%. And if the diameter is not big enough, it's safer to leave that aorta in because it's not really huge, and just leave it and keep the operation simple. However, if it reaches a certain diameter, let's say 5 or 6 centimeters, then it's so big that the risk is very high that it can dissect or rupture, and then we would take it out. So in the end, it's always a question about the diameter and the thickness of the aortic wall, if we would replace the aorta or not. So maybe, I assume with your brother, maybe his aorta is just a little bit enlarged, maybe just 3.9 or 4 centimeters, and then per guidelines, we would not replace the aorta. We would maybe even not call it an aneurysm nowadays because the guidelines say we should call it a dilation, not an aneurysm. That's just a nomenclature or term thing, but if the aneurysm is not big enough, we would not replace it because every procedure that we add to an open heart procedure makes it more complicated and adds up risks for complications.
And Kathy Jo?
I was just wondering, since Pete said, are you speaking today, if maybe he could just, for people that have the fears and mental health scares, he is a walking miracle. Can he talk for like 3 minutes? Please, Amy.
What Kathy Jo's talking about, Mike Sylvester, one of our annual people, he's coming all the way to Baltimore with us even in April for it.
Yes.
He's got a pretty amazing survivor story, but first, does anybody else have any other questions before we give Mike a few minutes?
I'll keep it short. 2016, I had a non-ST elevated myocardial infarction, heart attack. Drove myself to the hospital while I was having it. Following a stent being put in, woke up in the hospital bed and was vomiting and sweating, and some of the personnel there thought it was just the anesthesia wearing off. But fortunately for me, there was either a nurse or a young intern said, this is not right, and went and got the cardiologist. Cardiologist came in and said the magic words, we need a CT scan. Got a scan, had a massive dissection from my arch to my iliacs, woke up a month and a half later, had all kinds of other complications. Survived that and did my 36 sessions of cardiac rehab. Then it was about a year later, on the CT scan, I had a aneurysm in my proximal descending aorta, and we heard the surgeon here talk about the hybrid surgery. I had the aortic endograft put in. It required transposing and bypassing my carotids and subclavian, so that was 2 more surgeries, and then I had, I think it was 40 minutes of hypothermic circulatory arrest so they could do this complex surgery, and following that, I had a stroke, lost about a third of the brain on my right side, woke up blind and paralyzed and unable to speak, did 2 months of intensive therapy, went back to work. I'm a city letter carrier at the post office up north in Duluth. Then, so that was surgery number 5. Then in 2019, the stroke gave me epilepsy, and I had a seizure in my postal vehicle. Fortunately, I was parked in front of a busy retail store in Duluth. And then CT scan in 2019 determined that I needed 1 more surgery in the middle of COVID. So under complete lockdown, went in, had my final and hopefully final surgery. And that was in May of 2020, and went back to work at the post office 5 days after that surgery, and that was the last day of work that I've missed. So that's my story.
Mike, I just love all of your use of technology. You could be like one of the surgeons here, just so it just flows, right? Go ahead, Amy.
I remember that first year, and Mike was all scheduled, and they had their tickets, and he was going to come and see Night Ranger, and that was before you had the second surgery and the stroke. And we watched every day to see Mike, and we'd see his pictures, and he basically went against all the odds, because I believe you were told you would never be the same again. You'd never work again, you'd be in a nursing home, and yep, and that was in December? That would have been in December, January. Yeah, and in February, first week of February, Mike and his wife, Amy, what a great name, came down to Minneapolis, came to the Symposium, gave his talk, and got to meet one of his favorite bands, Night Ranger. So what an amazing story, making connections, and the music was a part of it. And I just, every day I'm thankful that you're around, Mike, and that you've been a part of this since the beginning. And
I've ever met that's had an A and B dissection, so amazing to see you here and how you've recovered. And if there's one thing about all these aneurysms and dissections is that no two are alike. Everybody has totally different stories and complications.
All right. Awesome. So thank you, everybody, for sharing your questions, your answers, your stories. This has been an amazing day. I wanted to just share that on the backs of your folders, there is a QR code, and we'd love for you guys to take a survey and tell us how we did this year on our symposium in Minneapolis. So please take some time to give us some feedback, because we're always looking for ways to improve the symposium, the VIP party, the concert. And speaking of those, tomorrow is a big day for us. We've got a VIP party happening at the Fillmore, followed by a concert with Pete and his band that fell to earth, and also followed by Rick Springfield. So we're really excited to be able to bring this to everybody, and thankfully we didn't get snowed out. So tonight we are following this with a cocktail reception outside, beginning I think any time until about 6:45, at which point we're gonna do a recognition dinner from 6:45 until 8 p.m. And if you have any questions, you can ask any of us over here, board members. Otherwise, thanks everybody for coming today.